Hello. Now we're going to go over documentation, uh, chapter 5. And documentation is really important. And, you know, you can be good at it or you can be bad at it. Uh, but you got to realize that this whole thing is documentation is so important, and you've got to understand why we have to do it, even though we may get this feeling of why do we have to document all this. Basically, because you're going to end up going to court somewhere in your career, and your patient care reporting that you do is the only thing that's going to be allowed for you to review regarding the case that you're on. So patient care reporting, also known as PCR, it's a record that you produce during a call, and it's known as a patient care report or pre-hospital care report. This report becomes part of the patient's permanent medical record. It's a legal document that records all care from dispatch to arrival at the hospital. It's a valuable source for research and trends in emergency medical care. It's a guide for continuing education, good or bad, and the quality improvement process. And it's a legal document that can be used as evidence in a court case. So the PCR, the patient care report, serves 6 functions. Continuity of care. It's a legal documentation, provides for education, administrative information, essential research recording, and evaluation and continuous quality improvement. So it's a record of patient care. It conveys information about the patient's assessment and management throughout the call. It's a legal document. The PCR can be subpoenaed in court for due to actions of negligence or your part as evidence in a criminal case. Provides for administrative functions such as insurance and billing information can be retrieved from your report. It aids in the education and research, and it provides for analysis for statistical gathering purposes. It can aid in additional funding for the entity that you work for, or more ambulances. And it also contributes to the quality improvement or quality assurance, which is the system that is in place by which calls are reviewed for adherence to medical protocols and organizational standards. It may reveal excellent care, so an attaboy can be provided, and it may reveal standard care or substandard of care, requiring retraining or re-education of the EMS provider on acceptable standards of care. So pre-hospital care reports, we have written reports and those that have the narrative areas and areas to record vital signs by checkboxes. We also have computerized reporting, which is what we use mostly today, and it's known as a ePCR, electronic patient care report. And it consists of bubble end boxes and recorded data that is scanned in for data storage and evaluation. Kind of think of it as a giant Scantron. We have pin-based computer systems. Just about everybody's moved forward to the pin-based computer records. And there's different companies out there that use the computer-based, pin-based reporting systems, such as Medusa. There's Zoll, there's Intermedics, there's RescueMedic, there's ESO. It's just whatever entity you work, they're going to have the system that they want to be used, and they're going to train you on it, and that's how you're going to make your report. But you also got to remember that if the system would go down for a little while, you may have to handwrite some stuff. So it's still important that you carry a little spiral notebook that fits in your shirt pocket or pant pocket. Carry a pen that you can jot down information, so when the system comes back up, you have it in front of you. So all you got to do, because if you try to do it from memory, you're going to forget something. So then you can put it in the computer because you may jotted down some notes. So there are some, there is what we call a minimum data set. And the minimum data set, this is, you have to put this information in, whether you want to or not. This is the minimum that you can put in. So each individual box on a PCR is called a data element. It's to aid in research, and for the U.S. Department of Transportation developed the minimum data set. And these are the minimum elements recommended to be included in all PCRs nationwide. You got to have the data element. You got to have run data, patient data, check boxes, and narrative. That's a minimum. So in the patient information area, you're going to gather this at the time of the initial contact with the patient, when your arrival on scene, and following interventions, and on arrival at the facility, at the receiving facility. You're going to get this information, the patient information. It's gathered at the time of the initial contact, on arrival at the scene, and then following all your interventions. The patient information that you must gather is the patient's chief complaint, their level of consciousness, don't forget about the AVPU, their mental status, Glasgow Coma Scale, GCS, the assessments, and vital signs. You're also going to put down skin perfusion, capillary refill time, skin color and temperature, pulse rate, respiratory rate and effort in the care that you provided. Administrative information that you need to get is the time of the incident report, the time of the incident, the unit notified, dispatch time, time of arrival at the patient, on scene time, time your unit left the scene, which is your transporting time, the time of arrival at the hospital would be the destination, and time of transfer of care when you go back in service. All this has to be documented. In the narrative area, we use different formats, but the SOAP format, based on subjective, objective, assessment, and plan, when you do your narrative, you don't just put down, oh, that I took Miss Smith to the hospital because she didn't feel good. That's not adequate. So your narrative information contains what describes your patient, such as their presentation, their assessment findings, your treatment that's provided, their patient's response to that treatment, and the transport information, why they went to this hospital and where they went. One of the best formats for documenting the narrative is the SOAP format. You want it to be subjective, objective, assessment, and a plan. So the subjective part of the narrative in the SOAP format, what the patient tells you. This is information gathered from the individual's point of view. It includes the patient's chief complaint, which should be in quotation marks, and symptoms such as I'm having chest pain. It includes what bystanders or family members tell you about the incident. It includes information like how the motor vehicle collision happened, how fast they might have been going, were they wearing their seatbelt, and did they have a positive loss of consciousness? It also includes pertinent negatives. Did they have a heart attack? Do they have chest pain? Do they have shortness of breath, nausea, vomiting? Do they have vertigo, general weakness? Pertinent negatives are things that should be associated with the patient's chief complaint, but aren't there. It focuses in on information that you did not directly observe yourself. In other words, if somebody's complaining of chest pain, it's very common to have some form of shortness of breath with it. And you ask your patient, are you having any difficulty breathing with this chest pain? If they tell you no, that would be considered a pertinent negative. Patient's complaining of chest pain and denies any shortness of breath. Patient has chest pain, denies any nausea or vomiting. If they said they vomited, then that's not a pertinent negative, because you would expect them possibly to vomit or have nausea and vomiting with chest pain. And so think of other things other than just chest pain. You might have somebody that's they're having difficulty breathing, but they don't have chest pain. That would be a pertinent negative. Think about the things that should be there associated with the patient's chief complaint, but aren't there. That's pertinent negative. The O for objective, your objective portion of your narrative should contain your examination of each area, including your observations of the scene. Avoid slang and radio codes. Use only standard abbreviations and write correct spelling and write legibly. Now you have a computer, so there's no room for misspelled words on a computer because it has a spell check. So you also need to document what you assessed, and if you didn't assess this area, you need to say did not assess on your chart. So the head, the eyes, the ears, the nose, the throat, the chest, the thorax, the abdomen, the pelvis, genitalia. You don't have to check genitalia if a patient stubbed their toe. That doesn't, you're not going to assess that. Extremities, skin color, condition. If you didn't assess the area, write or type on the computer, did not assess on your chart. And if they were normal, such as blood pressure, you would expect to be elevated or lower, right within normal limits. In the assessment part, use only standard abbreviations. Be careful if you put down SOB, because that could be misconstrued. Here the example we have is RO, chest pain. RO meaning rule out chest pain. And then second degree, secondary to angina pectoris. Those are legal medical shorthand abbreviations. We put the assessment, we can use abbreviations in our assessment part of the SOAP format. And then P, meaning plan, the narrative. So the plan would be, is what you did for the patient. We checked their ABCs, history, examination. We gave them oxygen. We gave oxygen at 15 liters a minute via non-rebreather, and we controlled any bleeding with 4x4s. The plan, what we did for the patient. And always in the report with transferred care to Parkland RN, Nurse Ratchet, or whoever it might be. Other information you can include in the narrative area, change in the patient after treatment. Did they improve or did they deteriorate? Your observations of the scene. Car was in the ditch on its side. The final patient disposition. Patient was delivered or was taken to Parkland Memorial Hospital and was transferred of care to nurse so-and-so. If they refuse care, you need to document that, and you need to document it with everything that you told them, why they should go to the hospital and be treated. And if you take them to the hospital, make sure that you put the staff person who continued the care, who you transferred that care to. We have some don'ts when it comes to documentation. On all the ePCRs and PCRs, you should avoid using radio codes, 10 codes, and non-standard abbreviations. Write legibly or type legibly in correct spelling. If it's not spelled right, it could be misread by others and may cause medical errors that could harm the patient. Your QI team is also going to be unable to read your report. And I can promise you, every report you do goes to QI to see if you did stuff right or if you did stuff wrong. If you did stuff right, you're going to be okay. But if you did stuff wrong, there's going to be problems. And try to remember that sloppy, poorly typed up PCRs indicates to be poor, inadequate, or haphazard patient care. Makes you a good target for being sued. If you're going to half-ass it, you're probably going to get sued. Make sure that any medical terms you used are used correctly. If you're not sure of them, look them up. If you can't remember it or you can't find it, just use everyday language to describe it in your narrative. And remember, if you don't document it, it didn't happen. You can go all the way to your grave saying, I put a non-rebreather mask or a nasal cannula on a patient, but you didn't document it, so it wasn't done. You're not going to be able to remember this call that you're writing up in 5 years when the lawyers get around to bringing up the negligence case to court. The only thing you've got is your documentation. Some other charting mnemonics that we can use the chart method or the cheated method. It's whatever system you use makes sure your information is accurate. Charting, chief complaint, H, history, A, assessment, R, treatment, treatment provided, R, and T, transport. Or you can use the cheated method. C, chief complaint, H, history, E, exam, A, assessment, T, treatment, E, evaluation, and D, disposition. Falsification of the PCR very well may lead to revocation of your certification. And in this business, when you get into fire service, if you lose your EMS certification, chances are you're going to lose your job. So make sure that you don't falsify patient care reports. It also leads to poor patient care. If an error in patient care occurs, document what did or did not happen. Don't falsify the report. And then take steps taken, if any, to correct the situation. There's 2 types of errors that can be committed during an EMS call. There's omission and there's commission. Omission means an important part of patient care is left out. Commission means actions were performed on the patient that were wrong or improper. Incorrect administration of a medication. You were supposed to give them nitroglycerin and you gave them an EpiPen. Commission. Omission and commission. If you ever have to do a handwritten report and correct an error on a handwritten report, you're going to draw a single line, horizontal line through the error, write the correct information besides it. You're not going to obliterate it. You're not going to use whiteout. Not going to scribble it out or anything. You're just going to draw a straight line through the error, then put the correct information next to it, initial it. And the reason why we don't want to completely cross out the error or obliterate it, it makes it appear that you were trying to hide your mistake. That's when you're going to have problems. If the error is discovered after the form is submitted, use a different color of ink. Correct the error with a single line cross out. Initial and date the correction. And that's the end of Chapter 5, documentation. Thing really make sure that you know the different data that you have to know about. what has to be included. So that's it for chapter 5.